Is your practice tired of wrestling with insurance denials, deciphering EOBs, and watching your revenue slip through the cracks? You are not alone. Welcome to The Claim Game, the podcast designed to cut through the confusion and provide you with the best practices for revenue cycle management success. We are Jeremy and Catherine Zug, and we've been with people just like you in the trenches. Each week, we'll break down complex billing processes, share real-world solutions from practices like yours, and ask questions of the game makers and changers of healthcare so you can take control of your revenue. Let's turn those claim denials into deposits and help you return to focusing on patient care. It's time to win the claim game.
Hi there. Occasionally on the podcast, we have the chance to interview really special people that change how healthcare works, people who make the way that healthcare works. And we take a strategic pause to talk to these people about their ways of thinking, how they're adapting to a changing healthcare landscape, and what they are thinking they will do in the future. And today we have the pleasure of interviewing Dr. Jeremy Friese, who is an absolute game changer. He's a man who would describe himself as a recovering Mayo Clinic physician. Jeremy is the founder and CEO of Humata Health, where he's using AI to finally fix the broken fax machine of healthcare. Before Humata, he was a serial entrepreneur and spent nearly 2 decades at the Mayo Clinic as an interventional radiologist and executive leader. He holds an MD from Mayo and an MBA from Harvard, giving him a really unique view of the system from both the clinical and business side of things. And today we're diving into how AI is actually reducing burnout and why the future of healthcare, and particularly prior authorization, depends on making administrative friction a thing of the past. Dr. Friese, welcome to the show. So tell us your background. How did you get involved in healthcare?
Great to spend time with you, Jeremy. It's always dangerous when you have this many Jeremys on a call. It doesn't happen very often.
No, it doesn't.
I grew up on a farm in South Dakota, and no doctors in my family. And so I went to undergrad to the academic powerhouse of the University of South Dakota to take over the family businesses. And what happened in my life is my mom was diagnosed with advanced breast cancer when I was an undergrad. And that was my first exposure to healthcare. And unfortunately, I say that I watched her die at the hands of our healthcare system. Despite having great doctors and great nurses, it was not a wonderful experience, and it didn't have a great outcome. But it did light a fire in me to help not only help patients, but try to help patients at scale. And so that was the impetus for me. I was, again, because nobody was in healthcare in my family, silly enough to think I had to go to medical school to jump in and try to solve the systemic aspects of the problem of healthcare. And so had the great pleasure of going to Mayo Medical School at the Mayo Clinic, and then spent 20 years there. And we can maybe get into some of that if you want to. But yeah, sort of my why story is the experience of watching my mom interface with the healthcare system. Wow. And frankly, not have a great experience either clinically or administratively. And that's why I've done everything that I've done in healthcare.
Because were you a radiologist at Mayo? Is that right?
I would describe myself as a recovering radiologist, interventional radiologist to be specific. And so I used x-rays to put needles in various parts of people's bodies, mainly to try to fix cardiovascular disease. But my thing that nobody really knows about is lymphatic surgery. And so there aren't very many of us around the world, but that's what Mayo is special at, turning ordinary people into super subspecialists so you can do great work.
Yeah. So the experience with your mom, one, I'm really sorry about that. That sucks. And so was it that said, like, we got to fix the system here?
So I'm old enough that when I went to medical school, there were not any MD, MBA programs. And so I tried to find something like that. But I knew that it was always this administrative side of healthcare that I wanted to spend time on. At that time, I thought that meant being a leader of a large health system like Mayo, or I grew up in South Dakota. So at the time it was called Sioux Valley. Now it's called Sanford. And then, as you get further on in your career and you get a couple of gray hairs, you understand that there are lots of different ways to try to do that. So that was, that's always been the game plan from day one.
Okay. So talk about the evolution of Humata. right? Because it's been a little bit of a journey for you, right? At this point?
Like everything sort of I'd say in the startup world, an overnight success after battling for 10 years. And so I've been on this prior auth journey for a decade across multiple different businesses. So I practiced at Mayo and helped run our radiology business. Half of all prior auths in the United States are imaging related. And so it became my department's problem to solve. On the administrative side, the other fact is literally I was an interventional radiologist and I was doing lymphatic procedures, of which, guess what? Every single one of those required a prior authorization. And so I would show up every morning and I'd have literally a stack of manila folders that Barb, my wonderful nurse, would say, okay, Dr. Friese, here's your phone calls you need to make for the day to, call everybody. And it was that experience on the provider side of trying to get my patients the care they deserved that has sort of led to this journey.
That's crazy. So you would spend a good part of your day just doing that?
The very first thing I would do every single day was deal with prior authorization. When I say I've been on this for 10, it's probably closer to 15 years. It really started, back in my administrative days at Mayo. And I'll tell you that it just became strikingly clear to me that the rules were changing enough. The process was laborious enough that it was not something that a human could solve.
Okay.
And even though we literally had warehouses of humans doing this work, and Barb was doing so much of this work, and I was doing so much of this work, one of the other hats that I wore is I ran what we called global business development. So it was my job to try to do partnerships with Apple and Google and other folks. And so it was sort of this combination of dealing with the problem and seeing how technology is changing the rest of the world and thinking this is the use case that we can and should solve in healthcare. And then at least my simple mind, you start with prior authorization, and that's one of the key challenges between providers and payers. And then you earn the right to do and try to solve a bunch of other things. And so we tried doing that during my Mayo days, and it just became clear that it was not just a Mayo problem; it was an industry problem, and that's what led me down this entrepreneurial path for the last decade.
So 10 years ago, we didn't have AI, right? So how were you trying to solve? I know that maybe this is a little far afield, perhaps, but how in the world did you try to solve prior authorization 10 years ago without the advent of AI?
I would say it a little bit differently.
Okay.
So we did have AI. We just didn't have it in the same form that we have today. And part of the reason that, it's an overnight success after a decade is because the AI today can do things that we couldn't even, 5 years ago, definitely not 10 years ago. And so there were pieces of the puzzle that could be solved with advanced technology 5+ years ago. And that was where we started. And it really comes back to, is an auth needed? What's the right information you have to submit? And then how do you keep track of the answer after the case? It's the same problem. You just deploy software differently to each of these problems today than what we were trying to do back then.
Right. How did you know this was a technology problem, not a policy issue? Right? Because couldn't you theoretically solve prior authorizations with a policy change?
So back then and today, I would say that my answer anyway is and. It is both a policy issue and a technology issue, and there are different pieces of the puzzle that each of them can attack. And so specifically on policy absolutely can have an impact on transparency, on interoperability and pipes. And those are the really key areas where regulation and policy can have an impact. And even with all of that stuff, you still need technology, as we like to say, on both sides of the fax machine, on the provider side and on the payer side, to solve the work that needs to be done. Because even when you have transparency and legitimate pipes, you still have a lot of work that needs to be done just on the provider side and just on the payer side. And so, I guess my answer, Jeremy, is you really need both. And so to think back then, the reason that I have always believed technology first is the solution here is because there frankly wasn't a policy appetite to do anything around prior auth.
Oh, that's very interesting. Talk more about that. 5
to 10 years ago. Yeah. Well, it wasn't I'll tell you, when I was raising capital from investors my first go round, call it 8 years ago, I had to tell them what prior authorization was. Like it wasn't part of the vernacular in the, I'll call it the health tech world, or certainly, on the Hill in DC or in state legislatures. And so it just hadn't risen to the point of something that policy really cared about. Mm-hmm. And so, my thinking was that's not going to happen, at least not in the immediate term. And so what can we do to start moving the needle? And that was frankly I knew how to solve things with technology. I didn't know how to solve things with regulation. And so it just, I saw a nail, I just started hitting it, and I've been hitting it for a long time.
What were some of the early successes that you had, 8 years ago, 10 years ago, trying to break through? Because you're trying, like you said, you're trying to solve issues on both sides of the fax machine, and providers don't trust payers, or big health systems have a adversarial relationship. So how were you able to bridge that really quickly 10 years ago?
Well, I'll say one of the reasons that I jumped on Prior Auth as the first use case to try to tackle is because even then, and I think it was more true to say this back then and than it is today, this adversarial relationship, as you've described, maybe was even more pronounced, and there was less of an appetite to work together. Even at that time, when having a conversation with a very large national payer, CEO, and without him knowing anything about what I was up to, he started talking about how much they as a payer despise prior authorization. Yeah. And that to me was that they despise it for different reasons than we as providers despise it, but it is a major problem for them. And so this was, even back then, and that was a light bulb for me to say, there is some common ground here that we can start to do something. And I spend all day talking to both providers and payers. And what I can tell you is while there's still that adversarial relationship, there really is a mutual appetite to try to do something better around prior auth, because it is a national problem that needs to be solved.
Yeah. What are some of the pain points that payers have with prior authorization, right? Because isn't the provider perspective that prior auth is just a means to delay care or deny payment? Right. So what would a payer say is their biggest issue with it?
A payer would say it has to exist because we have huge variability in the delivery of care across the United States. And so we need to help. We, a payer, would say we're in the business of making sure that the right care is delivered according to our policies. But if it isn't appropriate care, then we're in the business of trying to help maintain costs from escalating too much. And so prior auth is a way to try to help them maintain those costs or control those costs. Their biggest pain is that it's huge. Just like it's a huge administrative problem to submit a prior auth, it is also a huge administrative problem and expensive problem for them to review them on the other side. And so they literally have armies of doctors and nurses and others that are dealing with the intake and then the decisioning of these auths. And it's predominantly done with humans. So the reason it takes 1 to 4 weeks to get a decision back from a plan is because they're having someone like me read through the 100 pages of clinical notes that my nurse Barb sent over. And that's just not something you can do instantly. So their biggest pain point, Jeremy, is they feel like it can't go away because it helps them curtail costs. And it's a huge administrative burden to get through all of the prior auths that come in and to be able to make efficient decisions. And turns out the doctors are expensive, whether you're working on the provider side or the payer side. And they also recognize that they have a member engagement and a PR problem around prior auth. And so taking a month to make a decision doesn't make them look very good. And that's when, that's frankly when legislators and others start to get involved because of all of this bad PR.
Well, that's right. So I think one of the best stories I've ever heard about the necessity of prior authorization, whether we like it or not, I think it was, I'm going to get flamed on this, but it's either North or South Carolina. Did you remember this? Back from 2015, no. One of those states got rid of prior authorizations for some residential behavioral service. And the state had to roll that back because so much fraud entered the marketplace, or at least maybe not even fraud, but false statements. And they ran up something like a $200 million deficit because prior authorization does actually add value to everybody, right? So that's a good argument for prior authorization. That would be their side of the table on this particular topic. Yeah.
I'm a doc. I can say there's the most vast majority of care that's delivered is appropriate and should just be slide right through the prior auth process without any problem. But I personally think there's a very, very minuscule amount of true fraud, but I do think there is a fair bit of waste, and there's a fair bit of care that we deliver as doctors that, may not be straight down the fairway as appropriate for patients. And so a payer would say, look, we just need to have some guardrails. Otherwise, our already expensive system is going to be even dramatically more expensive.
Right. No, that makes total sense. So for a non-technical audience, right? Because you're like the doctor / technical guy, it seems like. How does this work? Like, this isn't just a chat bot that's going through and checking the boxes, right? I mean, you're building something pretty sophisticated. So can you explain how that works?
In a nutshell, I would say we're a software company, not necessarily an AI company, that solves the problem of prior auth for providers. And what that means is you have to use a lot of different technologies to solve particular aspects of a prior auth. And when I think of the main sort of 4 buckets of a prior auth, is an auth needed? If the answer is yes, then you got to submit the right information. Once you've submitted it, you've got to keep track of what is the payer giving you for an answer, yes, no, or something in between. And then you got to continue to monitor it before care is delivered. And so what we do is, I like to say, we're in the business of yes. How do you get through those processes using a variety of technologies to submit the right clinical information so you get more yeses and you get them more efficiently?
Yeah. So, sorry, let me walk through this again. So is an auth needed, yes or no?
Yep.
Would a provider just know that through experience? Would they check with the payer first? I mean, you're dealing with a lot of front-end problems already, even with that question, right?
Yeah. So that in and of itself is like a whole company.
Okay.
And so, and frankly, a whole separate technology stack. And so to do that, you either use your own historical knowledge, or if you're a computer company, you use historical knowledge. And that's kind of the way most people do it is, when we go into most practices, they've got a binder that says for United Plan X, CPT code Y, yes, prior auth needed, or et cetera. So you can do this based on what you've done historically. Or you can try to proactively, when Dr. Friese says we're going to do 77450, you then go to the payer and say, do I need an auth for this particular member, for this particular plan and CPT code? And you could go to that payer by phone, you could go to them by a fax, or you could go to their portal. And, that's kind of the way that it's done in a non-technology world. What we do is we've built that connectivity with the different payers and delegated entities so that our computers can ask their computers in real time. And what that means is instead of getting on a phone or scraping through a portal, we can tell you, turns out between 20 and 40% of the time, us as providers are submitting an auth and waiting for an answer that we don't even need to submit. And that's an enormous amount of work. That's also work that we're sending over to the payer where they're then having to review something and say, sorry, you don't even need an auth. And then just the other, sort of dirty little secret of the problem is the answer of whether an auth is needed, yes or no, for this particular plan, for this particular CPT code changes all the time.
Yeah, right. Exactly. Yeah.
Yeah, as anybody in practice knows. And so using that historical information, you're setting yourself up for failure if you're using historical information rather than actually going to the plan and asking the question.
Yeah, so how you guys can scrape that in real time so that when those changes get updated, when they're updated? Well,
and I would say we don't even go by the updates. We would go to whoever your insurer is with our software and say, does Jeremy need a prior auth to do a knee arthroscopy? And they would come back and say, yes, he does, or no, he doesn't. And then we would document that in the medical record. Because this is a really important point. A lot of the time, you then go on to get that knee arthroscopy and it gets denied. It says, well, you didn't have the prior auth right, or you didn't do it, or you didn't do it wrong, or something. And so to have that proof documented in the EMR is kind of a big deal.
And so you can go back and appeal the denial.
Because we've captured, and it's not, we've captured a screenshot of whatever the payer has said, or the direct information that the payer came back with. The problem with picking up the phone and calling somebody is is that like you could say, oh, we called and talked to Sally at 11:02 on, Monday, whatever. Does that actually work to get a claims denial overturned? Not really.
No.
And so by having the actual API connectivity or screenshot that you can show as proof actually can serve as the proof to get those things overturned.
So I imagine, but isn't there a friction there then with the payer? Or does the payer say, there's a little bit of a hole here, we got to fix that hole?
Turns out this comes back to the sort of provider payer, benefit side. Those are 40%, like let's just say the number is 40%. That's a whole lot of prior auths that are either coming in as a phone call or a fax or something that a doctor or nurse or somebody has to look at on the payer side and say, wait a minute, you guys, we don't even need a prior auth. So they're spending money on stuff that is of no value because they're doing work on something that doesn't even need an auth. And so it actually is beneficial for both sides of the fax machine to have software on one or the other side. And so one of the things that people in the industry talk about right now is this AI arms race, like AI on the provider side, fighting AI on the payer side. It turns out in prior auth, the opposite is true. The other side is actually benefiting by the counterparty having advanced technology.
Wow.
And this is a perfect example of if provider has AI, the payer is actually saving money as well and getting an efficiency boost. The same thing is true if payer has AI, with the key point to note here. If the payer's AI is helping say yes faster, that's good for providers and patients.
For sure.
That's a huge positive. There are, claims of payers using AI to deny care. I haven't seen that. If that is true, that would be horrible. As long as the AI on the payer side is being used to approve care and do it fast and efficient, that is very beneficial to doctors and their patients.
Yeah, that's right. And I think what you're referencing are the KFF articles where, we won't name any companies, but companies that are contracted to adjust prior authorization parameters to alter provider behavior, right? So that's where a lot of that comes from, I think. And it's very interesting. So, sorry, step one is a prior authorization needed, yes or no? That's like a whole ball of wax. And then you said the second step is if the answer is no, provide the service. If the answer is yes, then you have to gather the necessary information out of your EMR. So Jeremy, not everybody's using the same EMR, right? So I can already feel the tense conversation from providers. How does your system gather that information out of every EMR given the disparity in language?
Yeah, the answer is we don't do that for every EMR, and so. That's good. But you got to start somewhere, and so we start with the big EMRs and hit the Pareto principle of practices. The unfortunate fact is that means that we're not able to work with small individual practices at this point because it is difficult. There's real work to connect into these different EMRs, especially the smaller ones. To really do this second part of the puzzle well, one of two things can happen. Either you got to be connected in the EMR, as we've talked about, or you can have a non-integrated version where the human still has to pull the information out of the EMR and then put it in a platform like ours to understand so that you can do the submission. We're not doing that yet today, but I'm very excited to be moving in that direction so that we can service all of our brothers and sisters in smaller practices. And that will be available. It's just unfortunately not something that works today. And this also comes down to where we started earlier, where regulation can play a role. So by having common interoperability pipes and the regulation that say, EMR, you have to allow folks to be able to connect in a standard way, that will allow people like us to work with, smaller EMRs and smaller practices by being able to do that interoperability connectivity in a more standardized fashion.
Yeah. So you're talking about releasing a version where there's still a human being needed with keystrokes, right? Because you can't.
Yeah.
Practice Solutions only works in 4 EHRs, right? Because unless you know the EHR really well, you can really screw things up. I imagine it's the same thing in prior authorization, or no?
Yes. And each one of these, to solve prior auth, just like solving the claims problem, but especially it's a little bit different in prior auth in that we have to have access to usually a couple of years worth of actual clinical information, not just metadata. And so, my nurse would go into the EMR and pull not only my note, but also, the vascular surgeon's note and medical labs and imaging reports and all that stuff. So you got to not only have access to what is Jeremy's insurance and CPT code information. That stuff is pretty table stakes that you can do that through a structured fashion. But getting all of this clinical information, that's the tricky wiki. And frankly, that's what you got to be able to do if you're going to submit better auths. Wow. It's not just a matter of saying name, birth date, stuff. Like, you've got to do all of this clinical stuff. I mean, frankly, that's the hard work of submitting a good auth that historically, and for most people today, that's done by Barb or, someone like Barb. And increasingly, if you look forward, if I get my way, that will exclusively be done by a computer because they can do it faster, cheaper, so that Barb can go be the wonderful nurse that she should be.
Yeah, that's awesome. I mean, because what you're talking about is enormously complicated. I mean, it's very, very long for sure. This episode is brought to you by Jane, a practice management software and EMR built to support you in the day-to-day work of running your practice. If you're a health or wellness practitioner, you already know the care you provide starts well before your client arrives and extends far beyond the treatment room. Jane is there to support you in every part of that experience. With online booking, your clients can book at a time that works for them. And with features like notifications, they'll even be able to grab last-minute openings when they pop up. It's an easy way to keep your schedule full while getting your clients the care they need. During your appointment, Jane's AI-powered documentation feature can help you thoughtfully take notes so you can stay present with the person in front of you. And after appointments, you can end your time together on a healing note, not a transactional one, by charging the card on file. To learn more about how Jane can support you and your clients, head to jane.app/demo. And one last thing, if you're ready to get started with Jane, you can use my code in the show notes for a 1-month grace period on your new account. So, prior auth, yes or no? If yes, we got to get a bunch of information to tell the payer that this service is actually needed. What was the third step you said was needed?
So you've now submitted it to Blue Cross of whatever.
Yeah, right.
And then Blue Cross of whatever says, we'll get right back to you. And what that means is they'll get back to you anywhere from 1 to 28 days from now. Ooh. And so what that means for Barb is she is constantly like, okay, when can I schedule this patient for surgery? Some people say I'm not going to schedule. Some people say I'm going to schedule it for next Tuesday, just hoping that they give me an answer. And then she's picking up the phone or she's going to a portal and saying, okay, Blue Cross, have you made a decision? Okay, have you made a decision? Okay, have you made a decision? And you have no visibility about when that decision is coming. What we do in that scenario is 6 times a day through our interoperability network, ping Blue Cross or whatever and say, have you made a decision? Have you made a decision? Have you made a decision? And then we take that answer and put it directly back in the EMR. So no longer does Barb need to keep checking up on that. It's what we call prior auth statusing. And by doing that status with a computer, it frees her up from a lot of work that she was otherwise doing. And if the answer is yes, we have an answer, and yes, you're approved, that goes directly into your EMR and it falls off the prior authorization work list. So you never have to think about it again. You're now just going to go deliver care. And you're not doing any of this silliness going back and forth.
Okay, so then that leads to so you're pinging the payer 6 times, and is this like there's an AI agent doing all of this? Right?
It's an agent,
essentially. Yeah.
Well, so again, it's a bunch of different kinds of technology depending on how the payer is set up, but let's just call it an agent for ease's sake.
Yeah. Okay. So then the last step of the process is you have to make sure that either the prior authorization doesn't expire, right, or that it has to get updated, right?
So we call this post-authorization monitoring. And what that means is I've scheduled surgery for 30 days from now. I've got a window of these 30 days to do the surgery. And turns out life changes in 30 days. And so maybe it's at the beginning of the year and they've gotten a new insurance. Or maybe I am no longer practicing at this ASC and instead I'm going to do the surgery at the hospital. Or like a lot of different things can change. Site of service, Or maybe I've said, you know what, I'm also going to do, I was going to do just a CT head, but now I'm going to do a CT head and neck. Or like there are a lot of different examples of things that can change from the time you do the order and get the auth until the time care is delivered. And so we continually keep track of that. Wow. And what that means is if I've changed my mind and I've now moved it on the schedule over to the ASC or I've done something else, that if that information doesn't jive with the information that we got an approved prior auth for, we'll say, okay, Barb, something has changed. You now need to go back and either resubmit the auth or, in some way communicate with the payer to say we're doing something different because, oh, by the way, if you go and do surgery at a different site or for a different CPT code, you're going to get denied on the back end. Okay. Even though you had a prior auth for CPT 44994, if you do 44995, you're going to get denied. Doesn't matter that it's off slightly. Right. Or maybe you ran out of the window. It got delayed a week because the patient decided, I don't want to do it during Christmas. I'm going to do it the next week. Right. Sorry, you're going to get denied. And those are dollars that you now have just lost.
Yeah. And that happens in every industry. And I think that's where all the frustration comes from. So here's maybe a little bit of a itchy question, right? And I think everybody's dealing with this right now, where you have this really novel solution. You must have been very excited when AI came on the scene. I'm sure you were moving really quickly with all that stuff. What keeps Humata sticky in the market, right? What's to prevent somebody else from doing something similar or one of the EMRs doing it?
I'm really glad that we've transitioned from a time when I had to educate investors that this was a problem to solve and to give me money to go solve, to now we're in a world where everybody knows what prior auth is and every investor on the planet is throwing money at some little startup to try to solve the problem. So there's a gazillion of us out there trying to tackle this.
Okay.
So that is the reality. I think it's a wonderful thing, frankly. I like to say that Coke needs Pepsi. Coke continues to get better because Pepsi is nipping at its heels. That's awesome. And so the way we're gonna solve this problem at scale is no one company is going to do it. It's going to take a whole bunch of us that are doing it. We've got a massive head start on people, and I think we're pretty good at it. I think there are a bunch of other folks that are also tackling it. And just as you said, both big companies as well as EMRs and others. Part of the reason I think Earn the Right to Win is, number one, we're one of the only companies, maybe the only company, that truly is only focused on prior auth. And I think it's a big enough problem and enough of a difficult problem that, we're not also trying to do claims or payment integrity or, a bunch of scheduling or a bunch of other stuff. Turns out prior auth is hard enough to just focus on that. And we're also, I would say, the only company that thinks if you're really going to solve this for patients, you need to streamline the provider side and the payer side. And we're the only ones that say, we just really want to solve this for patients. And that means we're going to help service providers and payers only in prior authorization and nothing else. And so, there's a bunch of other folks that are coming to tackle it. I welcome that. That's good for the industry. That's good for patients. And we're just, we're going to keep running after it with everything we can.
No, I think you definitely do have a head start on it. I mean, I think that's why, like for us, you guys would be considered a game changer, right? Because you are very focused. You've been here for a long time. Those are great arguments for sure. And it wouldn't be that big of a step for you all to start thinking about like scheduling, for example. Like, is that a big leap or no? Like once you get a prior authorization approved, putting that on a schedule that you can also see in an EMR, or am I totally missing the mark on that?
Well, I alluded to this earlier. I mean, if I look back at the first deck when I was raising money, it was like it's a silly pyramid, and the peak of the pyramid is prior auth or maybe it was the foundation. I don't know. But by solving prior auth and having the connectivity between providers and payers to do it and be connected in the EMR, it earns you the right to be connected into front, middle, and back end of rev cycle, as well as all of the other patient engagement stuff. It turns out that prior auth is hard enough. It's taken us a long time, and there's still a lot more to do here. And so my approach is we're going to continue to be laser focused on prior auth. And I want to partner with everybody else in the rev cycle ecosystem to say, you continue to be the world's best scheduling solution. And let's figure out how to work together so that we can embed prior auth and connect it to scheduling and or whatever the other use case in the rev cycle or engagement would be.
Yeah, because what I don't think a lot of people know, or maybe they know it intuitively, but what they don't realize is that prior authorization, if you're in all of healthcare delivery, is the bottleneck, Like it is the limiting factor in the system, right? If we could identify one, that's what you would say. Is that right?
We didn't talk about this before, but I appreciate the plug. So I personally think about it like an hourglass,
Okay.
Those old fashioned hourglasses with prior auth is the thing in the middle, and you've got intake and you've got sort of all the billing and the claim stuff on the back end. You don't get to do the bottom of the hourglass. You don't get to do claims right unless you get the middle part right. And frankly, if you don't get the middle part right, and you're paying attention, you actually don't even get to deliver care and move on to that next stage. The other important point here is that 20%, if you look across healthcare, about 20% of claims by a dollar perspective flow through prior auth.
That's so many.
So the stuff, the high dollar stuff and the high value stuff run through prior auth. And so you got to get prior auth right in order to get the biggest bang for your buck that you deliver.
And it's really frustrating. I mean, that's why a lot of people are frustrated about it. So it's sort of like, if you wanted to use a different analogy, it'd be like merging in traffic, right? I mean, you're backed up for miles because the whole highway went down to one lane, right? And you're trying to shove all of commerce through this one lane. Unfortunately, this one lane thing is responsible for a lot of shenanigans. So how much with what you're building, are you trying to obsolete, you said Barb needs to be a good nurse, right? But are you trying to obsolete some administrative roles within payer and provider with what you're trying to do?
I mean, I think about it through the clinician's perspective, and I don't want them to have to deal with this problem to just be able to go take care of patients. I do think there will always be a percentage of prior auths that require a human to both submit and make a decision. I have no belief that our computers are going to get rid of rev cycle experts. Like they're still going to be needed for stuff. Are we going to need fewer prior auth specialists to do submissions and fewer prior auth specialists to make decisions? Yes. I do think that would be better for patients.
Yeah.
Because people are, in the process are slowing it down. And if we're, really doing it through the lens of how can we make this better for patients and make the process that much more efficient, I think we're going to need fewer people on both the provider side and payer side.
Yeah, you and I are on the same side of the table as that. There was a study done a couple of years ago that said we waste something like, again, I should have the source for this stuff when I say it, but we'll put it in the show notes. Something like $960 billion of provider time is wasted on prior authorization or billing and insurance related costs. And $960 billion, if a truck showed up to your office with $960 billion in cash, it'd probably cover the building you're sitting in.
I think a lot of people would be better off if we didn't have to spend that money.
Yeah. I mean, you just talked about it. You had a stack that you had to then call the insurance company on, and that doesn't make any sense. Like you didn't go to school for that. So yeah, it makes total sense. So you think there's some percentage of human touch needed still, even with the advent of AI and how that's maturing?
My crystal ball is no more valuable than anybody else's crystal ball, but my crystal ball would say, I think in the not too distant future, and I'm going to say 5 years or less, 90% of prior auth submissions are going to be done by a computer and a computer only.
That's great. I mean, that's great.
And 10-ish, let's call it something between 5 and 20 are going to need a human to lay eyes on it. And
why is that? Why do you think a human would still need to lay eyes on that many? Just because of complexity or technology fails and that kind of thing?
A lot. Complexity. So here's the other piece of the puzzle. Anybody that's been in the prior auth game understands what a medical policy looks like. So this medical policy, for those that are not prior auth people, is a PDF document, call it 20-page document that a plan puts out that says, if we're going to approve this drug for Sally, you have to meet this medical policy. And literally, again, 20 pages plus of if then, you got to prove that you have diabetes for this long, you've tried conservative therapy for this long, et cetera, et cetera. Not all of these things are black and white. Not all of these questions are black and white. The practice of medicine is a gray zone, ladies and gentlemen. Medical policies include a fair bit of gray zone. And so it will require a human to interpret the gray zone, and computers are going to get better and better at interpreting gray zone, but there will always be some, because they're again continue to change and medical policies are not perfect. So there will always be a component of these things that are frankly just going to require a human. And there's always going to be new drugs coming out, and there's I can't imagine a world where this is 100% done by a computer if we're going to do it optimally.
I really appreciate the clarity there, Jeremy, because I think we've known that for a long time, but trying to convince providers that that's the reality is really, really tough. So switching gears to policy, there's a new CMS rule, CMS 0057, that is restricting payers to make decisions faster and explain denials quicker and that kind of thing. And so you have a regulatory situation, right? Is that a regulatory tailwind, you think, for Humata and what you're trying to accomplish?
I think about it through a couple of lenses. The first is any attention on prior auth to move it forward, I think I would view as a tailwind. And so from a macro perspective, I would say that. Number two, it actually does move the ball forward from a what needs to happen standpoint to actually solve the problem. And so by having, I'm going to call it more standardized pipes and a more standardized way to get information from, A to B and what information you need to get from A to B. And then also, as you said, Jeremy, some kind of requirement on how soon you have to turn around and answer. That is hugely positive for patients, and it puts more attention on the work that we do. And so again, strong belief that the pipe part of it and the rules part of it are really important factors to move the whole industry forward. You still need technology on both sides because there's still a whole bunch of work that needs to be done on both sides to really get the prior auth done.
And I imagine having a 10-year head start on the payers, right? Because if you have this CMS rule that's dictating payers move faster, payers and health systems are likely not going to build out their own technology, right? You have a 10-year head start. That's kind of a long head start.
Most providers are not able to put the resources to try to solve, I would say, some of the prior auth problem themselves. And so they're today predominantly looking for partners like us to help solve. On the payer side, they do have more resources. And so many of the larger ones are throwing resources at it to try to solve some of it themselves. My answer to both sides is you should have both a partner, and some things you got to try to build yourself to really understand how hard it is. And maybe some things you can tackle. Maybe there are pieces of this puzzle you can tackle yourself. At the end of the day, it is a pretty specialized, difficult thing to solve, and believe that both providers and payers are going to be better off choosing a partner, whether it's us or somebody else, as we get the industry move forward.
Oh, 1,000%. Yeah. Are there industries that you're looking to work with first, or are you broad sweeping all healthcare verticals, any payer, any health system, any vertical?
We focus today on large health systems are our customers today, and we help them submit prior auths across every CPT code to every payer in the country. And excited to start to move throughout the provider landscape so that we can, again, help solve this problem for both doctors and nurses, but also, a patient, whether they go see a small rural provider in South Dakota or if, they go to a big health system in a big city.
Holy smokes. And you said half of the prior authorizations are radiology based or imaging?
Ballpark. Wow. Yeah, ballpark or imaging related. Yeah.
Wow, that's wild. Well, this has been really, really helpful. I appreciate all the clarity in what you all are doing. If you could give one piece of advice to a large health system or a large provider group struggling with prior authorization, what would you tell them?
Two things. Number one, it is a solvable problem. So, start to understand the landscape, and there will very soon, there already is, but I would say even more so very soon, be a very significant financial difference between the haves and the have-nots, the ones that have deployed software and AI and the ones that have not. This is one use case where there's a very clear ROI. And there are very clear dollars and cents tied to doing prior auth. And yes, I'm in this to help improve it for patients, but I'm also in it to help CFOs and make your bottom line better. And so number one, you just got to start looking. And, of course, we'd love to be in that mix and think we're the best out there, but you got to start looking. And then the other piece of the puzzle is there's also a change management component to solving the problem. And just because you've done it this way for literally the last 3 decades, you're going to have to do some things internally a little bit different than the way you have. You can't just say, here, now software, go solve this. And so we pride ourselves in helping groups work through that together. But it really is understand your process and how it works today, and then just start the process of talking to people like us to see what's available and what are savings that we could start to generate. And usually once people do that, they say this is a must-have, not nice to have pretty quickly.
Oh, that's great. Well, how do people follow along or get more of what you all are doing in their lives?
We work really hard to keep our website full of interesting content, whether you're a customer or not a customer, but try to put, thought-provoking leadership kind of pieces out there for folks to understand about regulation, understand about where technology is going, how it fits in on the provider and payer side. So humatahealth.com would be a great resource for folks to get started.
That's awesome. Well, thank you, Jeremy, for being here. We really appreciate it. And we look forward to following along too and seeing how things develop.
Appreciate it, everybody. Thanks, Jeremy. Great spending time with you.
Yeah, same. If you enjoyed today's episode of The Claim Game, please take a moment to leave us a rating and review wherever you listen to your podcasts. It really helps new listeners to find us. Make sure you never miss an episode by subscribing to The Claim Game on your favorite podcast app. Your feedback means so much to us. We want to provide valuable education about revenue cycle management. So if there's something we didn't cover in our topic that was a burning question for you, please let us know so we can try to get you the information you desire. You can find the links to all resources we mentioned in this episode in the show notes. And if you want to dive deeper into our resources, we have two places you can do that. First, you can go to our blog at practicesol.com/blog, where we have 8 years of educational blogs. If you want to learn more about what Practice Solutions does, reach out. We'd love to hear from you. Just go to practicesol.com to learn more and to connect with one of our awesome people on our team. Thanks for listening. We are Jeremy and Catherine Zug, and this is The Claim Game. See you at the game table next time.